CCTGMA.32 is a multinational phase 3 trial examining the effect of adjuvant metformin versus placebo on breast cancer outcomes. The trial arose from observations that obesity is associated with poor breast cancer outcomes and that obesity-related hyperinsulinemia may mediate this association. Metformin was selected for study because it promotes modest weight loss and a 15 to 20% reduction in fasting insulin in non-diabetic breast cancer survivors. In window of opportunity studies, it has been reported to lower Q67, and in preclinical research, it slows the growth of breast cancer. Furthermore, emerging evidence suggests that the use of metformin to treat diabetes in breast cancer patients may be associated with improved outcomes. Metformin may act indirectly by lowering circulating insulin levels, leading to reduced activation of insulin receptors present on most breast cancers and reduced PI3 kinase signaling. Or it may act directly on cancer cells through activation of AMP kinase, leading to mTOR inhibition, or it may act through other mechanisms. The primary objective of MA.32 was to examine the effect of metformin versus placebo for 5 years on invasive disease-free survival. Secondary objectives examine metformin effects on overall survival and other breast cancer outcomes, diabetes, cardiovascular disease, adverse events, BMI, and circulating metabolic factors. MA.32 enrolled subjects aged 18 to 74 with T1C to T3, N0 to N3, M0 breast cancer diagnosed during the previous year. Those with T1C, N0 disease were required to have additional adverse features. All received standard therapy and were required to be non-diabetic with a normal fasting sugar, adequate organ function, no excess alcohol intake, and no history of lactic acidosis. Randomization was stratified for hormone receptor status, BMI, HER2 status, and receipt of adjuvant chemo. Those on metformin received 850 milligrams BID for 5 years, including a 1-month ramp-up of 850 milligrams per day. Placebo subjects received an identical appearing caplet at the same times. Enrollment began in August 2010. Because of rapid accrual, entry criteria were altered in 2012 to enroll higher risk subjects. Enrollment of 3649 subjects was complete in March 2013. In March 2016, after a second interim analysis, futility was declared in hormone receptor negative subjects, and the intervention stopped in that group, but blinding and follow-up continued. An independent statistician redesigned the study to continue in hormone receptor positive subjects only, with the primary analysis at 544 IDFS events, providing 80% power to detect a hazard ratio of 0.78. Due to slowing event rates, in 2020, a decision was made to conduct a time-driven primary analysis with 465 IDFS events in hormone receptor positive subjects, providing 80% power to detect the original hazard ratio of 0.76. An intent to treat analysis was performed in all randomized subjects. Time to event survival was described using the Kaplan-Meier method. Stratified two-sided log rank tests were used to compare IDFS and other outcomes. Cox models were used to adjust for factors significantly associated with IDFS. I will show 3 sets of analyses. First, the primary analysis in hormone receptor positive subjects. Second, extended follow-up of the futility result in hormone receptor negative subjects. And third, an exploratory analysis in HER2 positive subjects. Starting with the primary analysis in receptor positive subjects. Median age of the 2,553 receptor positive subjects was 52 and mean BMI 29. The majority of subjects were postmenopausal, just over 90% Caucasian, and 80% had ECOG 0. Most tumors were T2, N0 to 1, and grade 2 or 3. 17% were HER2 positive. The majority of subjects received adjuvant chemotherapy, radiation, and hormone therapy, and these features were well balanced between study arms. Compliance with study drug was good in both arms, although slightly and significantly lower on the metformin arm. Reflecting known toxicities, metformin was associated with a modest and non-significant increase in grade 3 or greater toxicity, most of the excess relating to GI symptoms, including nausea, vomiting, bloating, and diarrhea. A similar pattern was seen for lower grade toxicity. Our primary IDFS analysis in hormone receptor positive subjects, just over 75% of the events were breast cancer related. and these events were evenly distributed between study arms with overlapping curves, hazard ratio 1.01, p 0.93. 75% of deaths were breast cancer related, and these were also evenly distributed between arms with overlapping survival curves, hazard ratio 1.1, p of 0.47. Results were similarly negative for distant disease-free survival, breast cancer-free interval, and invasive breast cancer-free survival. Thus, in our primary analysis, the addition of metformin to standard therapy in hormone receptor positive breast cancer did not improve IDFS, overall survival, or other outcomes. Metformin should not be used as breast cancer treatment in this population. Turning now to the follow-up of the futility result in hormone receptor negative subjects. In the 1,116 subjects in this group with 37 months of median drug exposure and follow-up to 96 months, there was no evidence of metformin benefit on IDFS, hazard ratio 1.01, or overall survival, hazard ratio 0.89. The lack of benefit of metformin on IDFS and overall survival in the receptor negative group that was identified at the second interim analysis was confirmed with longer follow-up. Metformin should not be used as breast cancer treatment in this population. Turning now to the exploratory analysis in HER2 positive breast cancer. This reflects stratification for HER2 at randomization. It was also informed by results of a 24-week neoadjuvant study in which a more than doubled pathologic complete response rate was seen when metformin was added to chemotherapy and trastuzumab in HER2 positive subjects who had at least one C allele of a pre-specified ATM-associated SNP. A similar pattern was not seen in placebo subjects. The SNP of interest has enhancer activity for the ATM gene, and it impacts expression of many other genes. The presence of any C allele of this SNP is associated with metformin benefit in diabetes. There were 620 HER2 positive subjects, 70% of whom were also hormone receptor positive. Almost all received chemotherapy and trastuzumab. With a follow-up of 96 months, there were 99 IDFS events and 47 deaths. In MA.32, there was an a priori plan to measure metformin versus placebo effects by SNP status, and 70% of our subjects had at least one C allele of the SNP of interest. In the full HER2 positive population, there were fewer IDFS events on the metformin arm, hazard ratio 0.64, and there were fewer deaths on the metformin arm, hazard ratio 0.53. Importantly, there was a significant interaction by SNP of the effective metformin on IDFS, those with any C allele having a hazard ratio of 0.51, whereas those with AA genotype having no evidence of benefit of metformin. A similar pattern was seen for overall survival. There was a significant SNP interaction, P of 0.02. Those with any C allele having a reduction in death, hazard ratio 0.35, whereas those with the AA genotype showing no evidence of metformin benefit. HER2 positive breast cancer is driven by increased PI3 kinase signaling, and this signaling is blocked by trastuzumab. We hypothesize that metformin may further block PI3 kinase signaling either by reducing signaling through the insulin receptor or acting directly on AMP kinase. In summary, subjects with HER2 positive breast cancer, notably those with at least one C allele of the ATM-associated SNP, experienced improved IDFS and overall survival on metformin. However, no p-value spend was allocated to this comparison. As a result, it requires replication in a prospective trial focusing on the HER2 positive population. In summary, metformin does not improve IDFS, overall survival, or other breast cancer outcomes in ER positive or ER negative breast cancer and should not be used as adjuvant treatment in those groups. Because diabetic subjects were not included in MA.32, this recommendation against the use of metformin should not be extrapolated to the use of metformin to treat diabetes in breast cancer patients. Exploratory analyses in HER2 positive breast cancer suggested a beneficial effect of metformin on IDFS and overall survival, notably in patients with at least one C allele of a pre-specified SNP. These observations should be replicated in future research. I'd like to thank our funders, the patients who participated in MA.32, as well as the investigators.